Hi there, and welcome to the voiceover PowerPoint for leukemia. I'm Dr. Alex, and this is the naturopathic clinical laboratory diagnosis lab portion. So just the lab values, lab testing, so forth for the 4 categories of leukemias. And we might find those 4 categories when we look at the hematopoietic stem cell picture again, and we focus in on myeloid line and progenitor line, or lymphoid line. We can see what where these names are derived when we start talking about the myeloid and the lymphoid leukemias. So in class, a question came up that allowed me to add a slide to this PowerPoint that kind of gives a big picture, a really basic, simple, big picture of the different types of leukemias. And we have lymphocytic or myelogenous, which, as I said, come from the myeloid progenitors and the lymphoid progenitors. Just think about the names. And those can be differentiated by just the cells that they are affecting, and they in this sentence being the leukemia. So the leukemia is affecting the lymphoid side. It's called lymphocytic leukemia, and when the cancer develops in the granulocytes or monocytes, that's the myeloid side. In the acute and chronic leukemia, well, acute leukemia is new or immature cells. In chronic leukemia, there aren't too many blasts. They're more mature and able to perform some of their functions. So those cells grow more slowly, the chronic side, and the number increases less quickly. So the disease on the chronic side progresses gradually, as opposed to the acute side, where the disease progresses quickly. So based on this classification, we see 4 dominant types of leukemia: the AML, the CML, that's acute and chronic myelogenous, and the ALL and CLL, which is acute and chronic lymphocytic. So the essentials of acute leukemias in general, we have a short course of symptoms, but we do have some symptoms. So we have fever, fatigue, easy bruising, and bleeding. We may have cytopenia or pancytopenia, but you're not going to wake up and say, oh, I think I have pancytopenia today. And you're not going to wake up and say, I think I have 20% or more of blasts in my bone marrow. You're going to wake up and say, wow, my gums didn't stop bleeding whenever I floss my teeth, and I've had this weird fever that won't go away, and I'm really super tired. All right, so we're going to cover again AML, ALL, CML, and CLL. So let's start with AML. And AML is higher among men than women. You can read the incidence there, and it's the most common leukemia in adults. It makes up 80% of the adult cases, and the vast majority of patients are 65%, 65% or older. Interesting. 65 years or older. If we say people are going to live 100 years, which is a great song, 100 Years to Live, what? That's such an awesome song. That guy is amazing. Are you kidding me? 5 for Fighting? The guy is fantastic. You should listen to him. So the vast majority of patients are 65 years or older. But anyway, my diatribe was going to be that if 65% of 100, then perhaps 65% is the same as 65 years. Who knows if we're talking about life. So acute myeloid leukemia, the etiology of AML is genetics, radiation, and toxic chemical exposure. Toxic chemicals actually make me sick. Weird. Those naturopaths. Acute myeloid leukemia, the most common presenting symptom: fatigue, anorexia, weight loss, fever without evident cause, easy bruising, and easy bleeding. So much of what I said a few slides back before the diatribe on the music. So AML again, symptoms are nonspecific. Most are related. So now let's make some sense of the symptoms, the nonspecific symptoms. Most are related to anemia, leukocytosis, leukopenia, leukocyte dysfunction, and thrombocytopenia. So how did I get there? Let's connect the dots. Anemia equals fatigue, or fatigue equals anemia, perhaps, so that we could make a leap and say the symptom of fatigue that we talked about back here was or could have been related to the anemia. And then the leukocytosis, leukopenia, and leukocyte dysfunction. What do we see there? We might see something that could be the fever without evident cause. So we might have had some sort of infection because we don't have anything to work with in terms of white blood cells or immune cells. And then thrombocytopenia, we have no platelets. Of course we're bleeding. All right. Symptoms are usually present for 3 months before the diagnosis is made. Other symptoms could be bone pain, lymphadenopathy, a nonspecific cough, headache. This list really bothers me because this is so common to so many things. So there's nothing on here that's pathognomonic for AML, but just so you can notice, there's the list. Physical findings: fever, splenomegaly, sternal tenderness, and that should be intuitive by now why a person may have an increased spleen and a sternal tenderness. Start thinking extramedullary hematopoiesis. Multiple bruises and bleeding should be intuitive when we think about the decrease in platelets. Unexplained infections, well, that should also be intuitive when we think about what white blood cells do for us. The GI bleed and the pulmonary, intracranial, and retinal hemorrhages, again, could be explained by the platelets. Laboratory workup, what do we know? NCD-1, well, we know that a CBC and a manual differential are probably going to be ordered, and we know clotting studies, PTT, PT, D-dimer, fibrinogen are options. We haven't really talked a lot about, in fact, we haven't talked at all about uric acid. We haven't talked much about bone marrow aspirates and biopsies, except to say we do them in some cases. And we haven't really talked much about chest x-rays. We will talk more about chest x-rays when we get into the upper respiratory stuff. And echocardiograms we haven't talked much about, but I know that you all know what those are. But for our purposes, we really need to focus on the CBC and the clotting studies. And should make sense to you why we're running CBC, because it is a cancer of blood, and the complete blood count would be a really nice way to know with a manual differential what's going on with those blood cells. And then the clotting studies, because we need to know why the person is bleeding. Hematologic findings are going to be normocytic normochromic anemia with a leukocytosis and a thrombocytopenia. And our leukocytosis is going to be 15,000 as the median, and then thrombocytopenia is going to be less than 100,000 on the platelets for AML. And the morphology and cytology, we're going to see what we talked about on the previous slide, greater than 20% myeloblasts in the blood and or bone marrow. We'll see our rods, which are just cytoplasmic granules, and you're not actually going to see those except for that one person in our class who's actually a laboratory technician who's probably, I think she said she had seen them. But you're probably just going to get a report that says this is what they saw. And positive myeloperoxidase reaction, we haven't talked about that yet, but I do want you to think about the Auer rods, the old dead white guy named Auer, who named this finding after himself, and I'll show you a picture here in a little bit. There's some blasts, and here's a little bit. There's the Auer rod. Okay, the prognostic factors depend on a lot of stuff. So age at diagnosis, what kind of comorbidities a person has, what are the chromosomal findings, what is the presenting leukocyte count, what is the circulating myeloblast count. These are all things that are going to account for prognosis. And the incidence of acute lymphoid leukemia, you can read that there. Did we just switch over? Oh yeah, we just switched from AML to ALL. Wow, I could have put a little divider slide in there, huh? Wow, that would have been helpful. So here we are, now we're on ALL, approximately 3,000 new cases a year. And these mostly affect children. So 2/3 of childhood leukemias are ALL. And this peaks at age 4, and that comprises less than 20% of the young adult leukemias. So we're looking at 2/3 in children and less than 20% in young adults. Maybe B-cell, T-cell, or the non-B, non-T, which is called the null type. So the etiology of ALL, who knows? Maybe Philadelphia chromosome, which I can't help but think of Philadelphia Freedom and Elton John. It's kind of, I guess it's music night. So viral infections may be an etiology of ALL, EBV and HIV, and you may have been, or the person may have been exposed to high energy radiation if they present with T-cell ALL. Toxic exposure, and then smoking in general, because smoking is in fact evil. So ALL, common symptoms: pallor, fatigue, shortness of breath, easy bruising, petechiae, weight loss, failure to thrive. Just the difference in weight loss and failure to thrive is what the age of the person is. Failure to thrive, we typically, as a term, as you probably know, that's used in much younger people. And then bone and or joint pain. All right, and then our physical findings are going to be fever, spleno and or hepatomegaly, lymphadenopathy, multiple bruises, petechiae, unexplained infections. All right, laboratory and radiographic workup is going to be, again, let's think about what we know. We know CBC with manual differential, and that's what we need to focus on. So what are we going to see on a CBC? Normocytic normochromic. And here's where the white blood cells are either less than 500 or greater than 25,000. Leukocytosis is the same as the previous one we talked about, and thrombocytopenia is now less. So we're going to have less than 50,000 instead of less than 100,000 that we saw on the previous one. All right, so that's the lab findings, and then there's some nice cells for us to look at. And then we look at the prognostic factors, adult versus childhood type, the morphology, the chromosomal findings, what the white blood cell count is doing. If it's greater than 50,000, it's not good. B cell type worse than the T cell type, and then lymphadenopathy and hepatosplenomegaly. Those are all considered in the prognosis. All right, let's move on to the chronic leukemias. The chronic leukemias, unlike the acute leukemias, are generally asymptomatic at presentation. So that's the day you went to the doctor and you got your annual checkup and you came back with a strikingly elevated white blood cell count, a marked left shift, so we're immature here. The Philadelphia chromosome may or may not be present, but we're not going to know that on a CBC. The person may have splenomegaly, typically they will, and they will likely have lymphocytosis. So again, asymptomatic at presentation. The incidence is, you can see there, and you can also see that it's higher again in men than women, and the vast majority of the CML patients are 40 years or older. And there's no clear etiology. The pathophysiology may be a genetic component, so there you go. Chromosomal anomaly, called the Philadelphia chromosome. All right, CML. Approximately 70% of patients are asymptomatic at the time of diagnosis, but they will or could have, depending on when they're diagnosed, lethargy, weight loss, increasing abdominal girth, easy bruising or bleeding, and excessive sweating. So it goes from 70% are asymptomatic to these pretty excessive symptoms. Physical findings, fever, spleno, hepatomegaly, bruising, and bleeding, and the gingiva is the most common. Laboratory and radiographic workup, what do I know? Well, I know about CBC with manual differential. I know about vitamin B. I might know about leukocyte alkaline phosphatase. I might not. I'm not really sure I don't think you guys have talked about that in any other class. So the ALK-phos and leukocyte alkaline phosphatase we'll be covering in next term. So chromosomal testing, you could do a test for the Philadelphia chromosome and a bone marrow biopsy. But what are you going to do, primary care folks? So CBC with manual differential. Okay. And hematologic findings, anemia, normochromic, normocytic, same old song. Leukocytosis now, the median is 20,000. Basophilia and thrombocytopenia, less than 100,000. And when we go back here, I said, what are you going to do, primary care folks? Well, basically, I should have said, what are you going to do, NCD-1 folks? Because really all you know at this point is CBC with manual differential. So we'll build on the rest of this in later terms. All right, so CML, there's some histology. Doesn't it make you think of how fun histology was? It certainly does me. All right, and then chronic myeloid leukemia is next, and we've got 3 phases: chronic phase, the accelerated phase, and the blast phase. So go back. Hematologic findings. We've got a median of 20,000, basophilia, and thrombocytopenia. All right, and then we go forward, and we see 3 phases: chronic, accelerated, and blast. The chronic phase, 3 to 5 years. Current treatment is with alpha interferon, and young patients should undergo a bone marrow transplant. The accelerated phase, new non-random cytogenic abnormalities in up to 80%. So this one's difficult to control. This is where myelofibrosis that we talked about in a previous voiceover can develop. Elevated leukocyte counts last several months before becoming blastic, and then the blast phase is when there's greater than 30% of blasts in the bone marrow or the blood. And the treatment with chemotherapy is similar to acute leukemia. Some patients will go into remission with treatment, but it's often short-lived. So there's a very not happy topic. Age at diagnosis, splenomegaly, blast greater than 5% in blood or marrow at the time of diagnosis, basophilia at greater than 7%, and platelets at greater than 700,000. That's going to be prognostic factors. All right, so now we just went from chronic myelogenous leukemia to chronic lymphocytic leukemia. Why didn't I put dividers between those? So the incidence now is what you see on the screen there, and it comprises 30% of all cases of leukemia, and it's the most common lymphoid leukemia, and it's almost exclusively due to B-cell clonal expansion, more common in men again, and most common in individuals less than 50, which we can contrast to our previous one that was greater than 65, I think. Let's go back. Nope. Vast majority of patients 40 or older. That's CML. Vast majority of patients 40 or older in chronic myelogenous leukemia. And now let's go with chronic lymphocytic, and we have most common individuals less than 50. So not a lot of contrast there. Okay, so etiology, several proposed genetic linkages. Could be EBV, HIV, Burkitt's, exposure to high energy radiation, toxic chemical exposure, and again, smoking is very bad for you. Approximately 70% are asymptomatic, as we've said a couple of times now. And then here are some symptoms if people have symptoms on presentation. Fever, pallor, fatigue, shortness of breath, easy bruising, gingival bleeding, weight loss, frequent infections. So you're kind of hearing a theme here, I hope, because these are starting to all sound just alike. Physical findings: fever, splenohepatomegaly, lymphadenopathy, multiple bruises, bleeding, gingiva, unexplained infections. This sounds exactly like the previous ones, so not a lot of difference going on here. The previous ones, I should say. CBC with manual differential. Once again, that's what we know, so that's what we're going to talk about. We're going to talk about the CBC. All this other stuff, peripheral smear, we know that too. All this other stuff is great, and you'll know more about it when we get there. So CLL is going to show you an increased number of lymphocytes on the smear, and you're going to see these things called smudge cells. Look them up on Dr. Google. B cells with CD19 and CD5 on a flow cytometry, but this is not something that we know right now. And small lymphocytic lymphoma is present in histology of a nodal biopsy. Okay, and there's CLL histology. There's a nice little smudge cell if you don't want to look it up on Dr. Google.